Welcome to Reimagine Radiology, a medical student podcast brought to you by the ACR Medical Student Section's Health, Innovation, and Technology Subcommittee. Through discussions with radiologists, researchers, and innovators, we aim to demystify AI, spark career inspiration, and highlight the ongoing transformation of our field. I'm Hannah Turhar, a fourth-year medical student at the University of Alabama at Birmingham, and the Health, Innovation, and Technology Liaison for the ACR Medical Student Section. Today, we're excited to welcome Dr. Tessa Cook. She's a radiologist and imaging informatics expert who focuses on applying AI to real-world clinical challenges in radiology. She's an associate professor at the Perelman School of Medicine at the University of Pennsylvania, vice chair of practice transformation in radiology, director of Penn's Imaging Informatics Fellowship, and modality chief of 3D and advanced imaging. Dr. Cook's work sits at the intersection of clinical imaging, informatics, and practical AI implementation, with a focus on quality improvement, education, and thoughtful integration of AI into patient care. So without further ado, let's get started. Dr. Cook, welcome to the podcast. How are you doing today?
I'm good, Hannah. Thanks so much for having me join.
Yeah, of course. We're so happy to have you on here, and we're excited to hear about your perspectives in imaging, informatics, and AI. So let's get right into it. We like to start these podcasts by asking a little bit about your background. Could you walk us through where you grew up, attended undergrad, medical school, and so on?
Sure. I grew up actually in suburban Philadelphia. Kind of funny. I live about 6 miles from my hometown after many, many years living in the city itself. I went to undergrad at Johns Hopkins. I also did a master's while I was there. I'm an engineer by training, biomedical engineering and computer science, and came back to Penn for my MD PhD and have been here ever since.
Awesome. Why did you decide to pursue radiology then?
So I always knew that even, during my time in engineering, I always knew medicine was on the horizon. And I kind of discovered radiology by accident while I was studying biomedical engineering. So one of the earliest research labs I worked in happened to be next door to a cardiac imaging lab. And so that was my first exposure to radiology. That was Dr. Elliot McVeigh's lab at Hopkins. And I think I got hooked very early and realized that, this was a way that I could sort of tie together my interest in medicine and patient care with my investment in engineering.
Yeah, 100% agree. I feel like radiology is the perfect intersection of technology with patient care. So I can see why you wanted to go into radiology with an engineering background. And what factors then led you to your decision to practice in an academic setting?
That's a great question. I think I really was inspired by the faculty that I learned from as a medical student and also as a resident. You know, it's a pretty wild thing to say that you learn from the people that literally wrote the textbook. You guys probably don't read books so much anymore, but my generation was still reading textbooks in residency. And, you'd look over at the shelf in the reading room and it would have the name of the attending that was sitting on the other side of you. And it was kind of a surreal experience. And I also come from a family of teachers. And so I think for me, the emphasis on education at a very early point in my life, the interest in research and innovation and, being able to learn from some really inspiring people all led me to academia.
Great. Yeah, that's wonderful to hear. It sounds like teaching is in your blood with your family being teachers as well. Could you describe a typical day for you then now at UPenn?
And I think that the part of my job that I love the most is that there is no such thing as a typical day. My week is generally a mix of clinical and non-clinical time. So my clinical days are covering cardiovascular imaging or cardiac MR or cardiac CT and working with residents and fellows. And we have a pretty busy clinical service where we also get to collaborate with folks from other specialties, including cardiac surgery, vascular surgery, and cardiology. So that's always interesting. My non-clinical days are really a mixture of things. And I think that's why it works for me because I am one of those people that is rarely just doing one thing at a time at work and also at home. And so my non-clinical days, tend to be a mixture of meetings related to sort of operational stuff, whether it's AI deployment here at Penn or evaluations, but also, checking in with students and residents that are working on research projects or innovation efforts. I am fortunate enough that I get to work on a number of enterprise-wide initiatives around improving how we deliver care, closing the follow-up loop, those sorts of things. So there's often meetings related to that or checking in with the team and actually, getting work done. My team at the Center for Practice Transformation is often online. And so, in addition to sort of our formal weekly check ins, we're working to troubleshoot stuff, brainstorm new ideas. So, always a mixture of, things that support the operational mission of the department, but also things that advance innovation and development and research. And so, it's super fun for that reason.
Yeah, it sounds fun. That's wonderful. And you mentioned you are the vice chair of practice transformations in the Department of Radiology at UPenn. What originally sparked your interest in informatics?
So I had, both during my time during my master's degree and then during my PhD, had been involved with what I sort of consider basic science informatics, developing image processing algorithms. It was before everything was AI related. And so, you know, learning how to manage data, working on sort of fundamental problems in imaging informatics. And I didn't really know what informatics was at the time. I thought of it as image analysis, image processing, those sorts of things. And then I got to residency and I met Dr. Woojin Kim and Dr. Bill Boone, and they were the ones that really introduced me to what I kind of work I do now, more clinically focused imaging informatics, working with pixel data, but also non pixel data, and really trying to apply those techniques to improve care delivery and to improve workforce wellness. And so, really, for me, residency was when I truly learned about imaging informatics and realized that that was, almost something you could specialize in. And it just dovetails with very nicely with my interest in solving problems and fixing things. And it was really the perfect fit.
Yeah, definitely. Your engineering background would lead you to do something in informatics where, like you said, you find a problem, you want to fix it. So, informatics gives you that great leeway into being able to do something like that. And I know you mentioned just in the beginning when you were talking about informatics, you didn't know what it was initially. And a lot of medical students think the same thing. They don't know what informatics is. So, for medical students who don't know what it is as a career path, how would you define it in simple terms?
Yeah, I really had no idea what it was as a medical student or even that it was, a field or a specialty. I think in very simple terms, imaging informatics uses data and information, because those are actually two different things, to create workflows and systems and processes that can be used in the clinic. And sometimes we're optimizing a process, sometimes we're developing an entirely new process. But imaging informatics really has to do with the data and the information and the systems that we interact with in the course of patient care.
Okay, that's great to know. And what is one misconception people have about AI and radiology that you wish that you could clear up immediately?
It's funny you asked me that question because I just saw something on LinkedIn that made me think exactly of this. There is a notion out in the world that AI has fixed radiology. And while think a lot of us would love for that to be true, I think, the reality is we're still trying to figure out how to use AI to deliver better care, to increase efficiency, reduce error, increase throughput, increase radiologist, wellness, quite frankly. And so that is the primary misconception. And I guess since this is for a medical student audience, I'll throw in a bonus one, which is that it is not going to take my job.
Great. I'm glad that that was mentioned in here because I will say so myself as a medical student. I hear other of my medical student friends thinking, oh, radiology is going to be taken over by AI. We don't even want to touch that. So I'm glad we're getting into this early and just putting it out there. Like AI is not going to be replaced by radiologists anytime soon. So thanks for putting that out there right in the beginning. I really enjoyed listening to your Imaging the Future podcast from last year. You talked about some of the innovative work that you've done with your informatics team. You You also talked about even earlier in this episode teaming with enterprises and working with residents with their projects. And on this podcast, you talked about your collaborations with the cancer care team and some of the projects that came out of the pandemic. Looking back, which projects have been the most rewarding for you, and what are you currently working on now?
It's funny. I just earlier this morning gave an update or sort of the closing final update on I think the project I must have been talking about last year with the cancer team. So, that project, it started out initially as a way to increase rates of imaging based screening for broadly for different kinds of cancers, although our primary use case was for hepatocellular carcinoma because it's one of the ones that is not really mature as a screening program that patients recognize, right? October is, breast cancer awareness month. People recognize that there's generally an awareness out in the world that, you should get a mammogram every year once you turn 40. Lung cancer screening is certainly catching up. Colonoscopy has gotten a lot of attention just in the last couple of weeks even. But, screening for liver cancer I think is less commonly known and talked about. But the thing that we learned in the process of working on that was really, the importance of engaging stakeholders, the success of an intervention, really making it easier for a clinician or a patient to do the right thing, of taking away that cognitive burden. And so we've been able to expand that to an enterprise wide effort now where we are looking at closing the loop on imaging follow ups. We are looking at making sure that patients who have testing that reveals a risk factor, whether it is for cancer or for something else, an aortic aneurysm, patients with aortic stenosis, patients who have positive findings on their colonoscopies, patients who might be at risk for heart failure, get the downstream care that they need because our healthcare systems are so complicated. It's easy for these things to fall through the cracks because there are so many results. And what we're trying to develop is systems that can kind of surface these findings so that someone can act on them and help a patient get the care that they need.
Yeah, definitely. Thank you for sharing. And it sounds like there's a little bit of entrepreneurship in there intertwined with informatics, talking to stakeholders and getting something to necessarily stick and have patients and the people working on it excited about it.
Yeah, absolutely. And honestly, it's not even entrepreneurship. It's getting engagement and buy-in because it's very hard. And that is all part of informatics. The technical part of informatics is really the smallest part of it and is honestly sometimes the easiest part of it. It's the change management and adoption piece of it that tends to require a lot more effort and can be more challenging. And anytime you're trying to make change in an organization, it's really important to know who your stakeholders are, know the team, the folks that are going to be affected and get them engaged early so it doesn't feel like you're imposing change on somebody because none of us like that, right? Getting folks to participate in the change, it generally to more success.
Definitely. And with these projects that you're working on in informatics, how do you structure your career? Is it split 50-50 between clinical radiology and informatics? Or is one more of a focus right now?
It's really kind of evolved over the years. I guess it sort of averages out to about 50-50, which is where I started out right after training, then swung a little bit to 60-40. Now happen to be more like 40-60, but it all sort of regresses to the mean, I guess. But, for me, it is important to keep a connection to the clinical environment because a lot of the problems that we solve with informatics are problems that you only experience if you're actually taking care of patients. And so having that connection back, I think, is important to kind of inform and identify those problems.
Absolutely. And still on the topic of informatics, in your talk presenting your work on clinical informatics at the SRG Pillar meeting for the Center for Intelligent Imaging at the University of California, San Francisco, you identified clinically relevant problems in medical imaging and emphasized starting with a real clinical pain points. How can trainees learn to recognize problems worth solving versus problems that are just technically interesting?
That's a good question. I mean, sometimes those problems are one and the same. The problems that we solve are not necessarily technically interesting all the time, but they're important ones to tackle because they make the experience of the workforce better. And I'm sure that this audience has, seen a lot of the stories recently about how there's a shortage of physicians, radiologists included, and we're all trying to do more with less. And a lot of times solving even a simple problem that just makes it easier to get through a day has a real impact and may not be the most technically innovative or exciting problem to solve, but it's still an important problem to solve. And so, learning how to recognize the problems worth solving, it's those problems that you kind of encounter every day in your workflow, right? The things where we all inherently go, oh, it's this again. I need a workaround for this because I keep running into this problem. You don't need a workaround, you need a solution. And if I think it's important to sort of talk about and identify these problems because they're pain points, they're points of friction. It makes it harder to deliver good care because you're trying to work around an inefficiency or a roadblock or a barrier or something. And we're all, as physicians, our priority is our patients. And the natural inclination is, all right, I just have to figure out how to get this done. But I wish people would talk about these problems more because there could often be system wide solutions that make it better for everybody.
Definitely. Collaboration is a big thing. And like you mentioned earlier, it doesn't need to be the most exciting problem that needs solving, but it could just be something as simple as just efficiency, day to day work that could, again, improve. So I'm glad that you mentioned that. What are some common mistakes you see when people try to apply AI to imaging without enough clinical grounding?
We keep running into this situation, and it's not even specific to AI, but if you're going to solve a problem, you have to understand the environment in which the solution is going to operate. I've had many conversations over the years with startups who say, oh, well, our product does X. That's great, but I don't need a product that does X. I need a product that does Y because X is not a problem in my workflow. And I think it becomes really important if you're going to start to build AI solutions for radiology, let's say, that you understand the job of the radiologist. And I think again, it really is worthwhile when it comes back to these, points of friction or pain points in the workflow. Starting with one of those as a problem that requires a solution is generally far better than building something and saying, what problem can I solve with this?
Right. That's a really good perspective. I mean, you have these businesses coming in and they're bringing out their shiny new technology, convincing radiologists that this might be something that they need, but they have no perspective of a radiologist. I think that's really important to, again, work with collaboration and bring radiologists into it so you can develop something that's more efficient and worth the radiologist's time to implement. 100% agree on that. I want to switch a little bit into questions about AI and AI integration and your AI and training experience in radiology paper in 2020 discusses how AI could become part of the radiology educational experience even before residents and fellows enter clinical practice. Could you walk us through how you envision that happening in the near future?
I suspect that a lot of you all have firsthand experience with that now, honestly, just because there are so many commercial tools out there that can be used to augment education. It's funny, you're reminding me that I wrote this paper. It's probably fairly outdated. I should go back and take a look and see how much of it is still relevant. I do remember the part about personalized education. And I think that part is still relevant, but we'll get to that in a second. There are so many tools that are not specific to medicine, right? Large language models, things like Notebook LM from Google, all of these tools that can be used to supplement how you learn, even in the preclinical environment. But I think one of the things that's really exciting about how we can use AI to augment education is this idea of personalized education. Penn is currently one of the sites that was fortunate enough to win a grant from the AMA related to precision education. So we're actively doing some of this research. But again, from a radiology specific standpoint, when you go through your clinical training, you certainly do independent study, but your in in-house clinical experience is a little bit predicated on the cases that you happen to see, the patients that happen to come for their imaging on any given day during the rotation, right? And that in turn, a little bit depends on where your program is located, right? A program that is located in the Northeast is going to see a very different case mix and diagnosis mix than a program that's located in the Pacific Northwest or in the South. And so we lament this sometimes as educators because, in a perfect world, every radiology resident would get to see the same sort of distribution of cases. And that's not the real world. But AI, I think, has the potential to personalize education a little bit to say, you know what? You're really good with aortic dissections, but you need to work on penetrating atherosclerotic ulcers or something like that, right? That was something that was really challenging to do with natural language processing even a few years ago. But some of the newer language models can actually help us to do that now and, sort of connect learners to the right resources and help them focus their efforts.
Yeah, thank you for sharing that perspective. I think that's really important to mention that somebody from a school or a program in the North may see different patients from the South, and it would be great to standardize everything, especially when residents go into the core exam and having to be tested on zebras they might not even seen before, and more because, it was a location barrier where that wasn't seen in that geographic region. So I think AI definitely could be used positively to just standardize the learning, and I think that's really great insight. Thank you for sharing that. The paper also talks about a challenge that you mentioned about learning to critically evaluate AI output rather than just trusting it. How do you think training programs can best teach that critical appraisal skill?
That is something I find myself thinking about pretty often, to be honest, because a lot of residency programs are trying to figure out what the optimal timing is to introduce AI in residency, because you could look at it in different ways. And there are multiple schools of thought on this, right? You can look at it as well. The whole point of learning radiology, the whole point of residency is to learn radiology. And if you're taking shortcuts with AI before you've truly learned radiology, what are the implications for your future practice? So that's one possible school of thought. Perhaps the other end of the extreme, or the other end of the spectrum, rather, is you know what, this technology is not going anywhere. And if the goal of residency is to teach you how to be a good radiologist, and being a good radiologist involves using AI, shouldn't you have it from the very beginning?
Definitely.
And then there's obviously a lot of opinions in between, right? About maybe do we expect a certain level of competency or, certain volume of cases before you're able to use AI. And so there are, as I said, there's a lot of discussion. I don't think we fully understand the right way to do this yet, but I'm hoping to try to figure that out in the years that follow. But it is very important to critically assess an AI output because the tendency perhaps is towards automation bias, right? Well, this was a computer generated result. Of course, it's correct. But that's not necessarily true. AI can make mistakes. It has a certain set of expected inputs. And if the input that it gets is different enough, maybe you're not going to get the answer that you want. It is also probabilistic in the sense that you could give it the same output and sometimes, or the same input and sometimes get different outputs. And so it's very important for folks that are using AI, whether you're still in training or you're finished training, to not abandon your clinical judgment. And if you're still in training, you might say, well, I don't yet have clinical judgment. No, you do. It's still evolving and it will continue to evolve even as you practice, perhaps not at the same speed, but you absolutely have clinical judgment. And so if something doesn't make sense, don't blindly trust AI because it's AI.
I could not agree more with that. I think the problem that we should be worried about AI integration is not necessarily it taking over our jobs, but becoming over reliant on it and not using our physician judgment and our critical judgment to make decisions with the human side of radiology. I think if we're not careful enough, we could easily be over reliant on that. So I'm glad you emphasized that point as well. And additionally, you said that just designing an AI-enabled curriculum for radiology residencies, something that was mentioned in that paper. If you could design an ideal AI-enabled curriculum for radiology residents from scratch, what would the first 6 months look like?
So I guess two ways to think of it. There's the AI curriculum to teach residents about AI, and there are actually a lot of really good examples out there from other sites. Walter Wiggins, when he was in Boston, developed one. Ali Tajani at UT Southwestern more recently developed one. So there are a lot of great examples out there. But there's teaching AI, and then there's teaching residents to practice with AI. And I just wanted to mention that those are sort of two different things. I think your question is more about teaching AI specifically. And I get this question a lot where, residents think that they need to know how to code or they need to understand sort of, how convolutional neural networks work and how transformers work. And if that's of interest to you, absolutely go for it and do the deep dive and learn it. But really, the more important thing is to understand at a high level, if you're using a particular AI model, how it works, what it can do, and more importantly, perhaps what it can't do. And then also to be mindful of that automation bias that we talked about earlier and to, evaluate results critically. It's no different really than if you were, when you pick up an exam to evaluate, to interpret and the image quality is not great, right? If you see an abnormality, you might think about whether the abnormality is a real abnormality or it's an artifact of the image quality or something like that. So we're always sort of thinking critically about what's in front of us. And if it's AI generated, I don't think that, that should change how we approach things. There are always also concerns around the ethics of AI, bias that could be baked into models unexpectedly. And, there's bias from different sources. We always sort of blame the data as the source of bias. Well, the training data was biased, therefore the model is biased. But that's not the only source of bias. There's bias from the data, there's bias from the model architecture, potentially. There's even bias that is introduced in our interactions with an AI model. And we've been talking about automation bias, right? As just one example. And so I think it's important to sort of be mindful of that because we, as the end users of the AI tool, might be the first ones to identify when something isn't working as it should. And so that's also, I think, an important aspect of this AI curriculum that I think residents should learn as soon as possible.
Definitely. And speaking of residents, in your experience, are current residents generally optimistic about AI's educational potential, or do they still worry about issues like you were mentioning, like automation or replacement of radiologists?
I think there's some cautious optimism. This technology is evolving very quickly. And I think, as with technology in general, the younger generations embrace it more quickly than the older generations. And so I think I've definitely seen that even with adoption of non radiology specific AI tools. And so I think there is some cautious optimism. There's certainly a desire to get more exposure to it and learn more about it as well. And again, as we're trying to figure out how best to incorporate it into the training experience, we're definitely going to be, leaning on our residents to get some guidance from them too.
Yeah, most definitely. And you mentioned that Penn got a grant from AMA to look into this. What steps are the training program at Penn? What are they currently taking in terms of integrating AI into radiology? And what gaps have you found still remain?
So the grant is actually a multi-department effort. So it's radiology, emergency medicine, internal medicine, and surgery all working together to figure out how to do precision education for learners in a variety of settings. So we're just one part of it. We're very grateful to be a part of it. And we are exploring in our piece of it, customizing feedback to residents on their call cases. So we've had a feedback system for over 10 years now that our faculty use.
So you mentioned earlier when we're talking about AI that your institution got a grant from the AMA. What does that entail, and how is that integrated into AI and the steps that you're currently taking to educate residents in their experience? And what gaps can you find that remain in terms of teaching AI and implementing that education into residency?
Yeah, we were very lucky to be part of that effort. So it's actually a multi-departmental effort. It's radiology, internal medicine, emergency medicine, and surgery, all exploring how we can use AI for precision education for learners in a variety of settings. And so the piece that we're exploring in radiology involves using AI to give personalized feedback to residents on their call cases. So we've had a system in place now for over a decade that the faculty can use to give residents feedback, but it's sort of high level feedback. Was this a major discrepancy? Was this a minor discrepancy? And so what we're exploring now is looking at how we can really kind of tailor that. Sort of like what I described earlier, right? You're really good at aortic aneurysms, but you need to work on finding dissections and penetrating ulcers or something along those lines. But a bit more really actionable feedback that we can give to our residents so that they can understand where they need to invest their time in learning and improving.
Great. Just diving and teasing a little bit more into that, what does that mean for the day to day experience of a resident? Does that translate into more time with mentors, faster feedback loops, or something else?
It's more of a customized, tailored feedback rather than, oh, here's my list of major discrepancies. I've got to go through each one and kind of figure out, what I said versus what the attending said. I would love to be able to give a resident sort of in addition to, the deep dive as they would like to do it or need to do it, sort of a more holistic analysis of a call shift or of a week of call shifts, as they try to figure out, okay, well, I felt really good with these kinds of cases and these kinds of diagnoses and perhaps less confident with these. And, within that second group, here are the areas where I should focus my studying going forward, kind of a thing.
Yeah, that sounds great. I'm excited to see that and hear about that being implemented because that sounds very promising. I want to switch gears a little bit to just AI in practice, still along the lines of AI, but I see you are a core faculty member in the RSNA Imaging AI certification program. For students and trainees who may not be familiar with it, what practical skills does RSNA Imaging AI certification program aim to teach?
So there are multiple RSNA imaging AI certificates now. There's the introductory, there's the advanced, and then there are multiple subspecialty certificates, including emergency medicine and emergency radiology and thoracic radiology. And they kind of build on one another. The introductory certificate is really there to introduce a lot of these concepts we're talking about. What does AI do? What can it do? What can't it do? How do you decide when AI is right? The value of the data, the risk of automation bias, the governance pieces that are involved, and then some hands-on experiences as well. And then the advanced certificate really builds on the fundamentals in the introductory, and then the specialty specific certificates really focus in on unique aspects of AI in those clinical areas and some tools that are available and some use cases that are relevant for those clinical specialties.
Wow, that sounds great. Are they making a certification program for med students yet? I'd love to get involved in that.
We'll talk. I'm
Yeah.
not sure, but it sounds like a neat idea.
Yeah, no, that sounds great. I think medical students interested in AI and informatics would love to hear that there is a program and certification like that they can get involved in. And speaking of medical students, how should students think about AI? Is a tool, a collaborator, or something else entirely?
I think the way that most of us are looking at AI now is as a new tool that we can use to innovate patient care. Certainly, it has implications beyond patient care in the sense that it can improve throughput, it can improve efficiency, it can improve the way that we analyze data. But all of that ultimately comes down to it's a new tool that can do some really interesting things. It doesn't yet, you could almost take that one step further and say, it's a collaborator in some instances. So I've been playing with Cloud Code a lot lately and have been able to use that to very quickly get some things done for talks and presentations and some other things that, would have easily taken me days, and I would have probably gotten frustrated and just given up at that point. So in those use cases, I could almost see AI as a collaborator, but those are all very non-clinical examples. You'll notice that I just gave you, right?
Yeah.
And so in the clinic, I think we are still very much at the stage where AI can do a lot that's really interesting, but we are the final arbiters of accuracy and, you know, what is what becomes part of the medical record, because we're still trying to figure out how this technology works and how to use it right. And so it is a very fascinating new tool that medical students will get to use in their future practice.
Yeah, definitely, and it's exciting. I mean, that answers my next question. I was gonna ask from your perspective, where is AI already improving radiology workflows? But it sounds like we're still figuring that out. But and then I would ask, what areas of radiology do you think are most overhyped in AI right now?
So I remember going to RSNA last year and everybody had agentic AI.
Mm,
When you walked the exhibit hall, that was the buzzword that you heard. And I truly wondered whether some of those use cases were in fact agentic AI or were just being called agentic AI because that's what the exhibitors thought people wanted to hear about. It's very much, the AI hype was so strong in 2017, 2018, and I feel like it kind of settled a little bit and we all really started focusing on meaningful use cases, and now we've reached that level of hype again. Honestly, what radiologists want to be able to see and what medical students should want to be able to see is things that really meaningfully move the needle on how we care for our patients. And that can be, you can define return on investment in many different ways, right? Most people, certainly people that are responsible for leadership of healthcare organizations and the ones that write the checks, want to see ROI defined in terms of dollars, because healthcare is expensive in the US in particular. And AI, being new technology, is also very expensive. And those two things are not congruent with one another. You can't spend a whole lot more money on new technology that you don't have to spend. And so I think there's just a lot of hype around what this technology can do and not enough attention being paid to how to implement it in a way that it truly impacts metrics that matter.
right. And I just wanna highlight what you just said earlier when you're answering this question about medical students really focusing on how we can move the needle for patient care. I think that's so important going into radiology where, like you said, we're gonna be exposed to all these new AI implementation by businesses. We really should be focusing on what is going to be best for the patient. So I think that's really important to emphasize. I'm glad you mentioned that. That is something that we have to continue to remember as we go into medical school, to residency, to attendings, and so on. So, thank you for mentioning that. Speaking of medical students, if a medical student wants to get involved in AI or informatics right now, what's the best first step?
Ooh, that's a good one. I would say the best first step, this is going to be a combo, two steps. Start learning. And there's lots of great resources from the ACR, from the RSNA, from SIM. I mean, there's so much information out there that's available online that was just not available when I was training. And that's a really valuable thing that everyone should take advantage of, is just it's really easy to learn. And the second thing to do is to find someone at your institution that's connected in the informatics world and reach out to them and say, hey, this sounds really interesting. I want to get more involved. How do I do that? And hopefully that leads to, a project where you can actually get some hands-on experience. It leads to connections in the informatics field. Imaging informatics in particular is a very small community. And so if you are able to get connected with someone at your organization, hopefully that leads to more connections in the broader community as well.
Great. Thank you for sharing. I know we mentioned earlier how medical students don't need to know about convoluted networks in order to get involved in informatics or AI, but are there any specific skills, clinical, technical, or communication based, that you think matter most early on when getting involved?
I think when you're first starting out, the two most important things are to be willing to learn and to be willing to, put yourself out there and get connected to people. It really is, I think, one of the most valuable things. And it was honestly something I was really terrible at, as a trainee was the networking part of it. And I really, I talk to students and residents from other programs all the time at meetings, or people reach out over email. And I really applaud the folks that can just cold email someone and say, "Hey, I'm really interested in this. Can you talk to me for 10 minutes?" And sometimes the answer you'll get back is no, but hopefully you get no, but here's a resource, and then you kind of build from there.
Oh, sorry.
No, I was going to say, I think in terms of, and again, you'll notice it's not a technical skill that I'm pointing out. It really is a human skill of just being willing to learn, being willing to do the work, and getting connections to folks who can, sort of help you in your journey.
Definitely. And it's great to hear that you're kind of giving a green light in terms of just cold emailing people, because I know for medical students it's daunting because you don't know this person, but this is a big guru like yourself in the world of radiology, and it's scary to just email them on the spot. But Dr. Cook gives the go ahead. And so, just for medical students listening to the podcast, it's not scary to cold email. Some people like yourself appreciate that. So that's great to know.
Not scary at all. Don't be disappointed if you don't get an answer, because I can't promise that everybody out there is going to answer your email. And quite honestly, if you're emailing me, you probably will get an answer, but it might be weeks later. So apologies in advance. But, I'd like to reward enthusiasm and a willingness to work. And I think a lot of people feel that way in our field. And we want to make sure that we nurture that next generation as well.
Absolutely. That's great to know. What's one thing you don't recommend students rush into, though, when it comes to AI?
I think you should be willing to learn and experiment with the tools that are out there, but not automatically assume that they're going to work for you. Not every one of these models. And if you play with different models, and I would encourage you all to, play with different things that are commercially available, not with patient data, of course, but, for learning, for, presentations, you'll see that each of these tools has strengths and weaknesses. And the same is true for AI you might use clinically. Not every AI works perfectly well. Not every AI is going to be the best tool for your patients, your data. And so, I think I would definitely say be open to what the technology can do, but don't automatically assume it's going to fix everything for you.
Definitely. That's a great outlook and perspective. Thank you for sharing that. I just want to switch a little bit into just the future of AI, just a few questions about that. Where do you realistically see AI in radiology in 5 to 10 years? And where do you not see it going?
I going to change up your question a little bit, Hannah. I will tell you where I would like to see it going. And where I would like to see it going is, again, as we said earlier, towards use cases that can really help us take better care of our patients. Anytime you hear about radiology, the things you hear about now are how the volume of the number of patients and the volume of exams that we're responsible for is growing at a rate that is outpacing the rate of the radiologist workforce growth, right? And if anything, you know, there was a time, particularly during the pandemic and a little bit after the pandemic, where the radiologist workforce was actually shrinking. And so, what I would like to see radiology AI do is really tackle problems that are going to help us. And foundation model draft reporting seems like a really interesting use case now. And there are a couple of papers out there showing that it can actually decrease interpretation time without negatively impacting accuracy. And that's very important. I would like to see us get away from this idea of replacing radiologists. And I'll say that with the disclaimer that, as we really understand how this technology can help us, and as the technology evolves, and we've seen how fast it evolves, the job of a radiologist is going to change. So for the medical students out there, if you're, shadowing in the reading room and you're sitting behind an attending who is, dictating cases at the workstation, your career may not necessarily look exactly like that. And it's important to sort of be aware of that and into that you can still have a very productive career as a radiologist. But the actual work that you do might look a little different because we have these new technologies to help us.
Yeah, thank you for sharing that perspective. Personally, for me, going into radiology and hopefully matching into the field, I'm excited about the changes that are to come about. And I'm excited and blessed to be able to talk to somebody that is changing the field of radiology like yourself and getting your perspective. So I'm glad you shared that insight with us. And last question on just the future outlook in your eyes. How do you think informatics will change the identity of radiologists in the future?
Ooh, I like that one. I think it already has changed our identity just in the last decade, because then for better or worse, we have AI to thank for that in the sense that I don't think that practices and departments universally saw the importance of informatics prior to AI. So I think the identity of radiologists and of informaticists, whether they're radiologists, informaticists, or, you know, physicians and other clinical specialties or non-physician informatics experts, I think our value has increased in the last decade already. And I think we'll sort of continue to do that. I think radiologists will find themselves even more so being sort of the synthesizers of information. We already are, right? In that when we issue an interpretation, we don't do it in isolation. We try to get as much information about the patient from the medical record. And I think in the future now we'll have AI to add on to that. And so it will just further evolve what we are already good at.
Absolutely. An exciting time to be in the field of radiology right now. Just some concluding questions. What are some goals you're currently working towards, passion projects or otherwise?
I have absolutely gone down the rabbit hole with vibe coding. I will say that, having a software development background somewhat in my past, mostly self-taught, but nonetheless, it's really it's a really great tool because I don't have hours to spend writing code anymore like I used to. And I don't necessarily have the knowledge at my fingertips that I used to have. And so vibe coding has been great because I have enough knowledge to be able to debug things or, fix them when AI doesn't give me exactly what I want, but also it saves me a ton of time. So I've been doing that with a variety of things, both in Databricks, in Claude Code, in Anaconda, in just a variety of environments, and it's super fun.
Yeah, it sounds fun. Yeah, that's awesome. Thanks for sharing that. Where can listeners find you online or on social media?
I am pretty much only on LinkedIn nowadays. I still have my Twitter account. I do have a Blue Sky account, but I find myself mostly gravitating to LinkedIn.
Okay, great. And then any final pieces of advice for our listeners?
2, always keep learning and don't believe everything you're told.
Definitely. And I just have a few rapid fire questions. Feel free to answer them on the spot whenever you're ready.
Okay.
What is one AI buzzword you'd happily retire?
Can I retire all the hype? I would love to retire all the
Just
hype.
the hype.
Just the hype. So let's get down to the real world.
Definitely. What's the best resource, book, paper, podcast, or course for students curious about informatics?
Ooh. The best part about being a student is that your membership to most professional societies doesn't cost you anything. So join SIM, the Society for Imaging Informatics and Medicine, join the ACR, join the RSNA, and consume all the educational content you can from all of these organizations.
That's great to hear. Absorb it like a sponge.
That's right.
Coffee or tea during long work days?
One of each. Coffee in the morning, tea in the afternoon.
Right. And I know before this podcast, you just got your coffee. So have the tea to look forward to then. Keep the caffeine. All right. Last one. One skill radiologists will need more of that has nothing to do with AI.
Communication.
Great, definitely. All right, that is it. Dr. Cook, thank you so much for joining us today and for sharing your insights on AI and informatics and practice transformation in radiology. We truly appreciate your thoughtful perspective on how technology can be implemented in ways that genuinely improve patient care and workflow. Thanks so much.
Thank you, Hannah. Really enjoyed chatting with you.